So without further delay, I would like to introduce one of our member of our board, Professor Maitra from MD Anderson. His resume is on the program. You can read about it. He was formerly the president of the American Pancreatic Association. He's truly an international leader in the field and has contributed significantly the advances of what we know about pancreatic cancer. And he will be addressing that issue to us.
Thank you. Okay, so thank you so much for having me here. Although, I mean, for those of you who know Bill and Augie, you know that when they call you, there's no choice. You just show up. So I am here because they picked up the phone and called me. So, the title of my talk is Why is Pancreatic Cancer So Hard to Treat and What Can We Do About It? And the way I'll present it is give a little bit of overview of the disease, and then we'll talk a little bit about the challenges that we face, but also the opportunities and the advances, because I just don't want this talk to be all about the challenges alone. This is the building I live in. The Pancreas Center at MD Anderson is on the 3rd floor, and it's a gorgeous building. If you're in Houston, please come and look us up. There's a lot of sunlight. So when we talk about tumors of the pancreas, this is getting a little bit into the weeds, but I think it's important to emphasize that pancreatic cancer, the one that we know of, is about 95% of the tumors that arise in the pancreas. I always use this inverted pyramid for med students when I'm teaching them. However, there are many other types of cancer that arise in the pancreas that are not pancreatic cancer, the one we know of and we call ductal adenocarcinoma in medical parlance, okay? So in the common sort of colloquial term, you think of pancreatic cancer as one single homogeneous entity, but actually there are many different types of cancers. Just yesterday, there's an MD Anderson patient who is a 12-year-old with pancreatic cancer, but it's a very different disease. Hopefully, will have very good prognosis. Has nothing to do with the ductal adenocarcinoma. That is the focus of this foundation, focus of our talk. I am surprised, but not really so, how often many of these different types of cancers are lumped together, especially on the internet, which is obviously the source of most genuine information that you can find. I was kidding about that. But if you put in pancreatic cancer, you have all of these famous people who apparently passed away from the same disease. But there's one here, Steve Jobs, who had a very different tumor type than all the others. And so it's very important, again, to emphasize that there are different types or subtypes of pancreatic cancer. They're not all the same. They're very different genetics, very different biology, very different treatments. And so the focus of the rest of my talk will actually be on this entity called pancreatic ductal adenocarcinoma, which for the most part is the most common tumor that arises in the pancreas. So I'm a pathologist by training, and I wanted to show a little bit of what this tumor looks like under the microscope. I know that there are survivors and patients, and I do think it's important and empowering to know, well, what was the tumor that I had? I don't know if you ever had a chance to look at it, but I think it's important to know that. And so you can grasp what it looks like. So this is basically what a pancreas cancer looks like. When a surgeon like Dr. Reber or Dr. Hines take out the tumor, this is what I see under the microscope. This haphazard growth of abnormal glands that doesn't look anything like the normal pancreas. The other thing that is very typical of pancreatic cancer, characteristic, in fact, to some extent, seen more than in any other tumor, is this pink stuff all around the cancer cells. And this stuff, all here, just trying to see if here we go. All of this pink stuff that you see, this is called a stroma. And this is not the cancer cells per se. This is the body responding to the cancer that's trying to spread. So here's a cancer, here's cancer, and all this stuff around it. This is the host response, or stroma. And the stroma in pancreatic cancer is very important for many reasons. One, it's trying to contain this cancer to stay inside, but it's also, in some respects, sending signals to the cancer cells to grow. And Steve Pandol, I don't know if Steve is here in the audience from Cedars, he's heavily involved with the foundation as well, but Steve is actually one of the world's experts on the pancreatic cancer stroma. And you can imagine this stroma with all of this pinkish material that's sort of encasing the cancer cells. It acts as a barrier to drugs effectively getting inside. And some scientists have used the analogy of oatmeal and raisin cookies I don't know if you're fond of those, but think of the cancer cells as the raisins that are embedded in the sea of oatmeal. And for the drugs to get to the raisins, they have to pass through the oatmeal. And so the stroma, in some respects, acts as a barrier to effective drug delivery. And this is certainly one of the challenges that we face, both in the research community as well as in the clinic. How do we get these drugs to get to these raisins and get rid of them? This is where pancreatic cancer, as it spreads from the pancreas, looks like. So these are lymphatics. Lymphatics are little channels that carry waste liquid or waste fluid from the organs. And this is also a common way for cancer cells to leave the pancreas and go to other organs, including lymph nodes and other organs outside of the pancreas. So this is an example of cancer cells that are getting out of the pancreas through these lymphatic channels. This is an example of cancer cells that are actually inside a blood vessel. So there's a lot of blood vessels, obviously, both encasing the pancreas as well as to the back of it. And one of the key decisions that surgeons like Dr. Reber and Heinz and others make in terms of resectability of your tumor is how much is it encasing a blood vessel. That's a very, very key determinant of operability. But the cancer cells can also invade the blood vessels. And the first organ outside of the pancreas that these blood vessels encounter is the liver, which is why liver metastases is so common in patients who have advanced disease, because that's the first sort of barrier that these cancer cells will encounter once they leave the pancreas. And finally, I just wanted to show this because one of the more common features that many patients present with is intractable back pain. Back pain is a very common symptom of pancreatic cancer, and one of the reasons that happens is because these cancer cells have this propensity to invade nerves, which in medical parlance we call perineural invasion, neural for nerve, and that's why you have this back pain, because it's a very nerve-heavy area, okay? So that's about as much pathology as I'm going to show. Now we'll talk a little bit about the challenges. So again, 4 challenges. What are the opportunities and what are we doing about it? The first challenge is that the incidence of pancreatic cancer is rising. And as Dr. Go mentioned in his introduction, it is slated to become one of the most common causes of cancer-related mortality in this country, third most common right now, but with the increasing rates, it might become the second most by 2030. So the rates are going up. And the challenge that we have with pancreatic cancer is it's often very difficult to pinpoint one specific cause like you have in other cancer types. For example, in lung cancer, 90% of lung cancers arise in smokers, and there's one attributable risk factor. If you say, to tell someone, listen, don't smoke because it increases your risk of lung cancer, and the person stops smoking, it's not that the risk goes away, but it significantly diminishes over their lifetime that they will get lung cancer, which is why anti-smoking campaigns exist, because you can say, this is an attributable risk factor for lung cancer, don't do it so you don't get lung cancer. For cervical cancer, there's a virus called human papillomavirus, which is almost always the cause of most cervical cancers. And there's a vaccine that now exists, and one of the big initiatives of the HPV moonshot that we have at MD Anderson is to have greater uptake of this vaccine rates amongst young girls as well as young boys, so that they can prevent getting HPV-associated cervical cancer in their lifetimes. So again, one cause, you can go after it, you can try to prevent it. The challenge with pancreatic cancer is that it's not one cause that you can pinpoint in most patients. We'll talk about some patients where there are attributable risk factors, but in most patients, you have the triathlete, you have the marathon runner, you have this person who's a vegan, has never had red meat in their lives, and they end up with pancreatic cancer, and you don't have an explanation for why they got it. And there was a paper that was written actually by colleagues of mine from Johns Hopkins, where they call cancer as a bad luck paradigm. And there are some cancers that you can, again, like smoking and lung cancer, HPV and cervical cancer, you can attribute 1 or 2 causes. But for cancers like pancreatic, there often isn't something that you can tell the patient, if you hadn't done that, you would not get this disease. And that's just a challenge that we face in the clinic every day. This is from a book where the protagonist's mom developed pancreatic cancer, and it's very realistic. This is the kind of conversation that happens all the time. what caused mama's pancreatic cancer? Just a case of bad luck. And this is a real challenge. So again, there's not often a single attributable risk factor for this disease. The second challenge that we face, and certainly one where I personally have a great passion of changing the landscape of where we are, is a late presentation and missed window of opportunity for early detection. Unfortunately, most of our pancreatic cancer patients are detected at an advanced stage of disease, but where they need to be detected is before they become clinically symptomatic. And the reason for that is by the time our patients present to us in the clinic, we are already treating an excruciatingly genetically complex disease where therapies may work or they may not. Now, work done by a former colleague of mine at Johns Hopkins, Chris Ikebuzia, who's now at Sloan Kettering, she did this beautiful study looking, sort of mapping the genetic progression of pancreatic cancer in patients who had terminal disease. And what she found through calculations was that the timeline for pancreatic cancer, from the time it begins as a single abnormal cell in the pancreas to the time you have widespread metastatic disease, is years, not months. It's not something that happens in the last 6 months or so. So there is clearly a wide window of opportunity, but most of our patients are being seen in this red box. So how do we turn back the clock? How do we go from detecting these patients at metastatic disease or even primary disease to something that's pre-invasive before it's even become an invasive cancer? So that's really the challenge that we have at this point in time. So the opportunity here is to better define populations that you would like to screen, because these populations are at increased risk for pancreatic cancer. Right now, there is no consensus tools available for screening everyone in the community. Like, for example, with colonoscopy or PSA testing or mammograms, if you're above a certain age and you go for your annual, you will get this test. That's because this is recommended, it's paid for, and there's evidence to suggest, at least in some cases, that it helps. There is nothing like that for pancreas. So the first thing we have to do is to create a sieve, if you so will, where if you have a certain clinical feature that places you at high risk, you automatically will be reflexed to the next level of screening. So define what these high-risk groups are, and then you have to come up with a test. And this will most likely be a blood test or a urine test or a saliva test that'll pinpoint those in this clinical high-risk groups that have the highest risk of actually having a cancer. And what do I mean by it cannot be an ivory tower assay? What this means is that this cannot be an assay or a or a test that's done in a big center like UCLA or MD Anderson. It's invasive. It costs $3,000 to do. It can't be that. In order for this to be amenable to practice, to reduce it to practice in the average physician's offices around the country, it has to be a test that's done relatively non-invasively. And most often by that, I mean it has to be a blood test, maybe a urine test. It can't be something that involves you coming to a big academic center. That's the next level. Once you have this abnormal test, then you refer to UCLA or to MD Anderson or Johns Hopkins or wherever. Then you have the next level of test that's more expensive, invasive, more involved. But the first test that you need to have is something that's relatively non-invasive, that's a blood test or something on those lines. So what are these high-risk groups? And certainly now in 2017, we know a lot more about those high-risk groups than we did even 15, 20 years ago. And the three that I want to talk about are familial pancreatic cancer, pancreatic cysts, and this last group, which is really interesting and where there's a lot of activity going on in the community, is adult new onset diabetes. So about 5 to 10% of patients with pancreatic cancer will give you a positive family history, that they have another first-degree relative, sometimes two, with pancreatic cancer. And we now know a lot more about what the exact genes are that could be causing that familial predisposition. The most common, this might come as a surprise to some of you, is actually the breast and ovarian cancer gene, BRCA2. About 5% of pancreatic cancers arise because of mutations in the germline, which is in something that you inherited because of germline mutations in BRCA2. So again, this is the most common known familial pancreatic cancer gene. There's a founder mutation in Ashkenazi Jewish populations that causes this increased risk. And certainly this is something that increasingly we are screening for in all patients, even those who don't give a positive family history, because now we know that there are some patients where even apparently sporadic pancreatic cancer, because there's no family history of it, still is caused by germline BRCA mutations. Now with DNA sequencing becoming cheaper and more easily available, this is something that we are trying to do more routinely in everyone so that we don't miss anyone who might have a germline mutation. Another example of a familial disease is familial melanoma. So these are patients who have moles and melanomas on their skin because of a mutation in a gene called P16, but they also have a very high risk of pancreatic cancer. And there are other syndromes like this that are even rarer. But for the most part, in many of these families, even today, we don't really have a known genetic basis except to say there are multiple family members. And one great example of that is actually President Carter's family. Unfortunately, he lost 5 family members, including both parents and 3 siblings to this disease. He himself, as you know, developed melanoma that responded beautifully to immunotherapy that was given. But we still don't really know what the underlying genetic mutation in this family is. And many families like that exist. But we still know that they are at higher risk, even if we don't know what the underlying gene is. And so there are programs around the country, including at UCLA and other places, where if you are an asymptomatic individual, but you come from a family that has multiple family members, you can get screened. You can undergo annual imaging tests, et cetera, to see if you yourself harbor something that looks like early pancreatic cancer. And we have been lucky in some of these instances. This is a case while I was at Johns Hopkins where we were able to find one of these asymptomatic family members who came from a high-risk family who had a disease that was literally caught in the act in the pancreas, just breaking through and becoming early cancer, but we were able to get the pancreas out in time. So there have been really wonderful success stories like this. This is a small subset of patients overall. Obviously, these families are not very common, thank goodness. But for those families, there are now opportunities for us to do screens. And again, there are clinics like this. This is from MD Anderson. This is a high-risk clinic at MD Anderson run by young faculty member Florencia McAllister. And clinics like this exist at most academic centers where if you come from such a high-risk family, you can enroll in a screening program and you can get screened before the development of pancreatic cancer. So that's high-risk group number 1. The second are patients with pancreatic cysts. So there has been a man-made epidemic, so to speak, almost, of the numbers of cysts that we are identifying every year in the pancreas. And these are basically fluid-filled sacs that you can pick up on CT scans or MRIs. And why are we picking up so many of them? One of the reasons is we're doing a lot more scans than ever. If you come with anything that's under your diaphragm, any weird pain, whatever, you get an ultrasound or a CT scan, it's the norm these days. And so every year, 22 million Americans have an abdominal CT scan, and about in 2% or 3% of these patients, and more if it's an elderly population, about 10%, you often find a pancreatic cyst that has nothing to do with the symptoms that cause the CT scan or MRI scan to be done in the first place. So these are asymptomatic cysts. So if you calculate the numbers, more than 500,000 pancreatic cysts are identified each year. So just to give you the scope of things in that context, here we go. So this is the number of new onset diabetes each year in the United States. That's 2 million. That's colorectal cancers right there. And this is the number of pancreatic cysts. So there's a lot of new cysts being diagnosed every year, right? And there are a lot of different types of cysts that are surgeons, and there are, I think, 5 UCLA GI surgeons here, which is just a testament to this amazing place. There are 5 GI surgeons in the room. They encounter all sorts of different cysts, many of which have nothing to do with pancreatic cancer. But there are a couple of subtypes, intraductal papillary mucinous neoplasm and mucinous cystic neoplasm, and you have to remember these names because there will be a test at the end of the talk. There will not be a test. But there are subtypes, a couple of subtypes that are associated with an increased risk of pancreatic cancer. Why is it important to know this? This is important because if you can get these cysts out at the point that they are not invasive, you've essentially cured the patient. Versus when they actually become invasive, it becomes potentially incurable. And this is real data from real series of patients where as long as the cysts are non-invasive, these patients are cured with surgery. Once they become invasive, the survival drops by 50%, okay? Now here are the caveats and the challenge. Just because you have a cyst in the pancreas doesn't mean you're going to develop pancreatic cancer. There are more than 500,000, as I said, of these cysts diagnosed each year. The vast majority, more than 90%, will never progress to pancreatic cancer in the lifetime. And one of the challenges that our surgical colleagues face is to determine which ones are the bad actors from the vast majority that will never progress and can be followed with surveillance. And where we come in, the research community, is to help our surgical colleagues identify those that are going to be bad actors by finding what we call biomarkers, which are in the blood or in the fluid that you get from these cysts themselves, and say, this is a bad actor, this is the one we should take out, and these other 95 other cysts you don't have to worry about. These patients can be followed, they can go home, relax. There's never going to be a lifetime risk of getting cancer in these cysts. So that's where the field is right now, but at least here we have an identifiable population, a subset of which is at increased risk. And our challenge right now, an opportunity I should say right now, is to find the biomarkers that will help us weed out the bad actors and get those cysts out in time before they become pancreatic cancer. The third area of high risk in this population is very interesting. This is something that we have only recognized in the last 10 years or so. It's a great example of how careful clinical documentation allows you to pick up a relationship between two apparently unrelated medical phenomena. Much of this work was done from Mayo Clinic and by Suresh Chari. He's a gastroenterologist at Mayo Clinic. And what he found was that between 25 to 50% of pancreatic cancer patients, so that's a large number, have new onset diabetes as their first symptom. And as you can see here, this line right here is when they develop, these are patients who developed symptoms of pancreatic cancer, jaundice, weight loss, abdominal pain, all the classical symptoms. But when you go back and look at their blood sugar levels, anywhere between 2 to 3 years before that, the blood sugar starts rising, and it doesn't respond to diabetic medications like it does in a regular type 2 diabetes. So it can predate cancer diagnosis by 2 years. Here's the challenge. I just showed you in that cyst picture, that graph, where we have 2 million new onset diabetics in the country every year. Obviously, we don't have 2 million pancreatic cancers, thank God. Only 1 in 100 new onset diabetic patients above 50 have an underlying pancreatic cancer, where the cancer is causing the diabetes. The other 99 are just usual type 2 diabetes that will respond to exercise and medicines and dietary control. How do we find the needle in a haystack? That's the big challenge and the big opportunity for us right now. One is not to miss that 1% who has an underlying cancer that's causing the diabetes, but also not to get the other 99 panic that they might be harboring something that's a pancreatic cancer. So to address this, and thanks in large part to the incredible efforts of Dr. Go, who kept knocking at the door and kept knocking at the door till finally the NIDDK and NCI, which is the National Cancer Institute, and the National Institute for Diabetes, Digestive Diseases, and Kidney Diseases, for the first time in their existence, came together to fund a consortium, which is a group of centers. There are 10 such centers around the country, including right here at Cedars. This is Steve Pandole, and Steve is leading the Cedars-Sinai LA center. There are 10 centers like this, and MD Anderson is actually the sort of the national coordinating center. We support all 10 of these centers. And the intent is to create what we call a new onset diabetes or NOD cohort. So this will be a population of 10,000 adult new onset diabetics around the country, and I'm the co-PI the co-lead of this cohort. along with Suresh Chari from Mayo and Steve from Cedars-Sinai here. And we will follow these patients, these 10,000 new onset diabetics, for 3 years. We'll collect blood samples, urine samples, other samples, and we expect that about 100 of this. And why you need 10,000? Because fortunately, the risk is only 1 in 100. About 100 of these patients will develop pancreatic cancer, and we want to identify these patients before they get the cancer manifest, because we can potentially identify this disease at the time when it's resectable. You can take it out, you can get these patients to our surgeons, but also to understand, well, what is changing in their blood or their urine that will allow us to detect that one person out of the 99, and separate from the 99, who just have usual type 2 diabetes. What is there in their blood or the urine that might tell us this person needs a scan, this person might be having a pancreatic cancer? So that's a big study that's being done, and the NCI and NDDK have come through, to their credit, in actually funding this study and funding this large cohort. But the other intent of this cohort, beyond just the 10 centers, is also to get the message out there for our primary care docs, that if somebody above the age of 50 presents with diabetes and has unusual symptoms, the diabetes is not responding to medicines, or the person is losing weight, but the diabetes is not going away, which is very strange, because most of the time your physician will tell you, well, lose some weight and your diabetes will be better. But here the person is losing weight and the diabetes is not getting away. It should at least trigger some suspicion that this is something that's awry, this is not your usual diabetes. It's surprising how many physicians in the community don't even know about this connection between new onset diabetes and pancreas cancer. And so one of the intents of this consortium is also education, and get the message out there. I have given talks where people have come up to me after the talk and, and said, with my dad, he had pancreatic cancer, and 2 years before that he had new onset diabetes, and they kept missing it. They had no idea that this was connected to the cancer. So this happens all the time. And so there's also a need for us to get this message out in the community, to the community docs. Listen, if you have someone who has an atypical course of diabetes, think of pancreatic cancer. So I've talked about the word biomarker quite a bit, right? And so basically what it is something that we're looking for in the blood that triggers a warning that this person may be having a pancreatic cancer. And this is important in all of these high-risk groups that we talked about: families, cysts, diabetics. The problem with biomarkers right now in the field is the one FDA-approved biomarker, CA19-9, is terrible when it comes to early disease. It has a sensitivity of 25 to 50%. What that means is that at best, it's picking 1 out of every 2 patients who may have pancreatic cancer. At worst, it means it's missing as many as 3 out of 4. So it's not a very good marker, but it's the only one that we have. So there's a lot of work going on through the consortia that I just talked about, as well as other NCI-funded consortia, to identify biomarker subtypes. And there's a lot of fancy papers that have been published looking at different types of biomarkers. This is all good. The problem we have with the field is these are all small studies that have been done in single institutions, and the kind of rigor you need to have an FDA-approved biomarker, 10,000 patients, different clinical trials, we just haven't done that. So what we need right now, and the NCI has bought into it, and they're really trying to find the money to fund this sort of a national effort, sort of the Marshall Plan in biomarkers, if you so will, for pancreatic cancer, is to do this chopped, you do a chopped of biomarkers where you pit these biomarkers against each other, a bake-off, if you so will, and then the ones that don't work, the sucky ones, fall by the wayside. The creme de la creme lifts to the top, and you keep going till you end up with something that's a tangible panel of biomarkers, because this is a lot of stuff I just talked about. You can't do this in every patient. You need 2 or 3 things at most that you can send off to Quest or wherever to basically get the result that you need. So to do this biomarker bake-off and end up, as a community, with a blood test for pancreatic cancer. So this is happening. This is an opportunity that we have in front of us. As Dr. Go mentioned, the NCI has come through with money. Now the eyes of the community and the National Cancer Institute are on us to make sure that we deliver. But there's another challenge. Okay, this is not an easy path. So let's just say you have a perfect biomarker, and it works, it picks up every single cancer that you have. But now what? The challenge that we have in the field is also about imaging. Okay, the CT scans and MRIs, sometimes their limits, the limit of detection is not enough to pick up the small cancers. And as we have better and better biomarkers that are able to pick up abnormalities from smaller and smaller tumors, we also need to have better imaging tools at our hand. And so there's a lot of work going on. Shameless plug for MD Anderson a little bit here. There's a great guy, Eugene Coy, who's doing some really fancy stuff. But this is happening all around the country, even here at UCLA. People are doing great stuff, basically making the current standard of care tools even better using computational algorithms and other bioinformatics tools where typically something that the naked eye would miss, now they're able to pick up using these computational tools. So this is the summary of this entire portion of my talk. Early detection of pancreatic cancer is likely to have the greatest effect on long-term survival. Cohorts at risk for pancreatic cancer have been identified. I talked about 3. And a biomarker bake-off, this national plan, Marshall Plan for biomarkers, combined with better imaging tools, should lead to a practical solution. It's very important that this is practical for screening at risk and eventually the general population at large. And there's a reason I show this Marlboro Man is because there is an association between smoking and pancreatic cancer. It's nowhere near as high as lung, but it is something that confers a higher risk. And so this is my please don't smoke pitch to the audience. All right, moving on, challenge number 3. This is the only Houston connection that I'll talk about in my talk, which is the enchilada. You gotta have a little bit of Texas in your talk. So KRAS is the big enchilada of pancreatic cancer. What do I mean by that? So this is actually a cloud, a word cloud, where all the genes that have ever been found abnormal in pancreatic cancer are depicted, and the size of the letters is proportional to the number of times or the frequency that a particular gene is abnormal. And what's the big one, the big 4 letters that are staring back at you? It's KRAS, right? That's the big player. It's mutated or abnormal in the vast majority, more than 90% of pancreatic cancers. So if there's one take-home message about genetics of pancreatic cancer that I want you to walk out with from this, is pancreatic cancer is a RAS-driven cancer. This oncogene is incredibly important in this disease, in this cancer. It's found in the earliest precursor or pre-invasive stages at a very high level. So this is the first genetic alteration. When we look at human pancreatic cancers and the pre-invasive lesions surrounding those cancers, the one thing we always find is KRAS. So this happens really early. If you take mouse models and you express KRAS in their pancreas, these models develop pancreatic cancer with KRAS alone. If you shut off that KRAS in these animal models using tools that we have, genetic tools, the tumor regresses and goes away. So KRAS is important not only in the beginning of pancreatic cancer, it's also important in the maintenance. But for 30 years, we've tried to hit KRAS with a drug, and we have simply not succeeded, okay? Every time we get there, Lucy pulls the ball away. So, but that doesn't mean that KRAS is not a good target. And this is about the only thing I'll say about KRAS as we sort of, finish this section, which is when something is abnormal in 92% of pancreatic cancers, you can't give up on it. And so the NCI recognizes that. They have actually initiated a national RAS initiative that's headed by Frank McCormick, who used to be at UCSF and now has actually moved to the DC area to head this initiative. There's a website, and they're working not only within the NCI, but with investigators around the country to make drugs that target RAS in pancreatic cancer. So this is a really important target. We haven't been able to hit it so far, but that doesn't mean we should give up, and that's going on. There's some really exciting data coming out, and I'm telling you, in the next couple of years, you will see some of these drugs going into the clinic. One other area in this pie chart of the pancreatic cancer genome that I want to talk about is defective DNA repair. So about 5 to 10% of pancreatic cancer patients have defective DNA repair because of either mutations in a gene that we talked about previously in the context of families, BRCA2, but there are other genes as well. And as I mentioned, sometimes you just have families where you don't know what the underlying mutation is or the underlying abnormality is, but you have 2 or more patients who have family members who have either pancreatic cancer or other cancers associated with BRCA, such as breast and ovarian. So we call these BRCA-NES families. So many of these patients, they have a defect in DNA repair in their tumors. And the reason this is important is you have drugs available now that are clinically available that you can use to treat these patients with these drugs. And sometimes the results are dramatic. So these are some results shared by Eileen O'Reilly, a friend of mine from Sloan Kettering. 2 patients who had metastatic pancreatic cancer, but they had this defect in their cancer. And when she used these drugs, the responses were dramatic. So it's not a big subset, unfortunately, but the opportunity for us is how can we make this 5% group apply to the rest of the cancers? Is there any way that we can artificially induce DNA damage defects in these cancers so that all pancreatic cancers start behaving like these extreme responders that I show here? All right, I'm almost at the last stage of my talk. So I've talked a lot about genes today, and I know that Dr. Brand will also talk about genes. His talk is about genes. But it's not just about genes, okay? There is also the universe of pancreatic cancers outside the genes. Remember, I talked about the stroma. So when you look at pancreatic cancers in the lab, like a graduate student is culturing these pancreatic cancer cells, this is what it looks like in a petri dish. It's just a bunch of cells in a petri dish. That's all you have. But in the body, it's not just the pancreatic cancer cells. You have a lot of other things going on. And so you have the stroma, but you also have immune cells. Okay? So you have all of these immune cells that are basically your body trying to get rid of the cancer, and you must have heard of this term immunotherapy that is becoming such a vogue in so many diseases. And what immunotherapy is doing is basically it's revving up your body's immune system to get rid of the cancer. And this is a picture of Jim Allison, who's at MD Anderson. He's the father of modern cancer immunotherapy. He discovered this drug called ipilimumab, which is actually approved by the FDA for melanoma. And he's actually wearing a tie that has ipilimumab on it. So I thought it was a cool thing to take a picture of. So anyway, so this is Jim. He's a great guy. And so in our body, we have checkpoints, which are brakes on our T cells. And he discovered the first example of a checkpoint inhibitor which removes these brakes and allows these T cells to basically go and attack tumor cells. And you've heard a lot about this in the lay press. There are advertisements everywhere. There's a Parker Institute created by Sean Parker that's focused on cancer immunotherapy. There are a lot of drugs out there that have been approved by the FDA or in the process of being approved. This is results from lung cancer, where immunotherapy is starting to show some really fantastic results. God, I wish we had results like this in pancreas. If you have lung cancer these days, the patients who have lung cancer, their lung cancer is you look for this particular molecule in their lung cancer so that you can give them this drug. So the field is moving at a breathtaking pace in many cancer types like melanoma or lung cancer. Here again, we have this challenge with pancreatic, which is the trials that have been done so far, unfortunately, have not worked. And this is some of the trials that I'm showing here. We've had some vaccine failures last year. So immunotherapy remains still a very difficult challenge for us in this disease. And there are many reasons for that I'm not going into, but suffices to say that, again, this challenge translates into an opportunity. And in many centers around the country, including MD Anderson, and I know for sure you're here, we are trying a lot of different strategies to overcome this barrier to immunotherapy in pancreatic cancer. And I'm telling you, if there's one area that I have great faith in terms of where we'll make major advances in the treatment of pancreatic cancer, it's going to be in immunotherapy. I really, truly believe that we are seeing some incredible responses in our lab, and we just have to make sure that we translate those effectively into our patients. So, it's not all gloom and doom. There are challenges, but there are also incredible opportunities. There's a lot happening. The NCI knows that we need to make progress in this disease. And thanks to foundations like the Hirschberg, we are bringing into the field some incredible people who never worked in pancreatic cancer, but who are now putting their efforts into this disease. And this is a picture of Mary Sharkey, who kindly allowed me to show her slide, show her face. She was resected in 2001 at MD Anderson. And February 2017, she's alive and well. She works with our pancreatic cancer patients. She's a part of our Moonshot program. She's the advocate on our Moonshot. Just a wonderful person. And so there are long-term survivors. We have so many in this room here today that we'll hear from later on. And so this is a saying from a pancreatic cancer survivor. She was kind enough to share this with me. I had my doubts that any pancreatic cancer diagnosis could have good survivor stories to be told. And I've added this emphasis, but here I am today. I think this is very important. And I plan to be here to watch my kids and grandkids grow and love them with all my heart in the many years to come. So I think this really encompasses the hope and optimism that we all feel in the research community. And I've worked in this disease for over 15 years. There was a lot of pessimism, but I'm really optimistic that we will make an advances in this disease in the next few years, thanks to everything that's going on in the research arena and in the clinic. So I want to thank Augie. Augie, you are truly the Energizer Bunny of pancreatic cancer research. Many of us will be out of juice, but you're going to just keep going and going and going. And I think the seed grant program that you have started that have brought so many individuals into the field is just incredible. I can't even speak enough highly of that. So thank you for having me, and thank you, Dr. Go. I appreciate this.